I'm Dr. Praveen, mm, MD from AIMS. Serima. I just wanted to know a brief detail that classes என்னென்ன படிச்சிருக்கீங்க actually. PSM Dilesh, are you there online? சொல்லு. What are the basic things which you have learned?
Sir,
Hmm.
screening patti and
Okay, screening. Health and
from
concept of health
programs,
முடிஞ்சா. Health programs, okay.
health programs அப்புறம் இது ஏடிஸ் கியூலெக்ஸ் அந்த மாதிரி மஸ்கிட்டோஸ்
Okay. Environmental வேற. Nutrition.
என்விரான்மெண்டல் நியூட்ரிஷன் ஓவர்
Okay.
சார்.
Nutrition is over. Okay, வேற. Concept of health and disease முடிஞ்சா.
முடிஞ்சு
Concept of
சார்.
health and
கான்செப்ட்
disease.
ஆஃப்
Okay. Health
முடிஞ்சு
and
சார்.
disease. சரி, okay. I expect Dilesh to be active and online. Fine.
ஓகே சார்.
Okay. I hope we'll start the class. See, this will be a revision class and I'll be discussing about only the basic superficial things. I'm not going to go into detail as you have very less time. So we'll have a class for around 3 hours approx. So I want you all to be attentive. And we'll have a break in between. Fine. So look, see, the first thing we'll discuss about the mortality rates. Mortality rates பொறுத்த வரைக்கும் crude death rate is first thing which you have to know. So crude death rate என்ன நமக்கு தெரியணும் அப்படின்னா வந்து what does that mean? Crude death rate னா வந்து it is the number of dead people compared to the media population. So இது question கிடையாது. So what is the question? What is the simplest measure of mortality அப்படின்னு கேட்பாங்க. So the first question you have to know is that the simplest measure of mortality is crude death rate number one. And current, what is the crude death rate of India அப்படின்னு கேட்டாங்கன்னா you have to say it is 6. Fine. Crude death rate பொறுத்த வரைக்கும் we have learned two things. Number one, it is the simplest measure of mortality. And number two, currently the standard for crude death rate is 6. So what is crude death rate? Just for our understanding, we have to know. It is the number of dead divided by the mid-year population. That's crude death rate. Coming on to the next, neonatal. What does this neonatal mean? Neonatal, if it is less than 28 days, ஒரு குழந்தை பிறந்து 28 நாளைக்குள்ள, you call it neonates. Fine. So the first point what you have to remember is neonate. The definition for neonate is less than 28 days. So neonatal mortality rate அப்படின்னா வந்து number of dead in newborn children less than 28 days divided by the total live births. Total live births into 1000. Fine. So neonatal mortality rate. Appadina, first thing you have to remember is that the number of deaths less than 28 days. That is the first point you have to remember. And the second point, you have total live births divided by into 1000. So what is the most common cause of neonatal mortality rate? It is prematurity. Prematurity is the most common cause. Current India, it is 20 per 1000 live births. You have to know 3 points regarding neonatal mortality rate. Number one, 28 days கம்மியா இருந்தா most common cause வந்து prematurity. Number three வந்து இந்தியால it is around 20 per 1000 live births. Fine. Number three, what does this perinatal mean? Perinatal அப்படின்னா வந்து we call it late fetal plus early neonates. So what does that mean? 28 வாரத்துக்கு மேல, more than 28 weeks and less than 1 week after birth. Less than 1 week after birth. So total number of deaths more than 28 weeks or less than 1 week divided by total births. Total birth, both live plus dead. Okay. So இதுல நம்ம என்ன ஞாபகம் வச்சுக்கணும் அப்படின்னா வந்து you have to remember three things. Perinatal அப்படின்னு சொல்லும் போது it is around the natal period, before and after. So it is more than 28 weeks. The first point is 28 weeks you have to remember. The second point is the weight of the baby has to be more than 1000 grams. The third point is the crown heel length. CHL னா என்ன? Crown heel length. Has to be more than 35 centimeters. So I'll expect you to remember 3 points for perinatal mortality rate. Number one, the weight of the baby has to be more than 1000 grams. Two, the gestation period has to be more than 28 weeks. And three, the crown length, heel length has to be more than 35 centimeters. Fine. Dilesh, are you okay? What are the three
Yes,
things
sir.
you have learned right? என்னென்ன பார்த்துருக்கோம் இப்போ crude death rateல என்னென்ன பார்த்துருக்கோம் crude death
Crude
rateனா
death rate, number of dead people divided by mid-year population.
ஓகே நம்ம கொஸ்டின் அது கிடையாது, அது கேட்க போறது கிடையாது. நம்ம கொஸ்டின் வந்து சிம்பிளஸ்ட் மெஷர் ஆஃப் மார்டாலிட்டின்னு ஒரு கொஸ்டின் வந்தா நீ crude death rateன்னு சொல்லணும். அதுதான் ஃபர்ஸ்ட் கொஸ்டின்.
Yes, sir.
ஃபைன். செகண்ட் பாயிண்ட் நம்ம என்ன வச்சுக்கணும், நம்பர் 6. ஏன்னா இந்தியாவில் வந்து
India,
வாட் இஸ் த
6,
கரண்ட்
sir.
ஸ்டேட்டஸ் அப்படின்னா 6.
6.
ஃபைன். ஓகே, நியோனேட்டல்
Okay, sir.
மார்டாலிட்டி ரேட் பொறுத்த வரைக்கும் நியோனேட் அப்படின்னா எத்தனை நாள் வரைக்கும் நியோனேட்னு சொல்றோம், இட் இஸ் லெஸ் தேன் 28 days.
Less than 20 days.
அந்த 28ங்கிறது இம்பார்ட்டன்ட். செகண்ட் வந்து என்ன மோஸ்ட் காமன் காஸ்ன்னு கேட்க வாய்ப்பு இருக்கு, அப்படின்னா ப்ரீமெச்சூரிட்டின்னு தான் நீ சொல்லணும். அதே மாதிரி கரண்ட் ஸ்டாண்டர்ட்ஸ்
Okay.
படி இட் இஸ் 20. ஃபைன். இப்போ தேர்ட்
Okay,
வந்து
sir.
பெரிநேட்டல். பெரிநேட்டல்னா வந்து லேட் ஃபீட்டல் அண்ட் அர்லி நியூனேட். அப்போ லேட் ஃபீட்டல்னா என்ன இருக்குன்னா மோர் தென் 28 weeks அண்ட் லெஸ் தென் 1 week. ஃபைன்.
Okay, sir.
நம்பர் ஆஃப் டெத்ஸ் டிவைடட் பை டோட்டல் லைஃப். சரி, இப்போ இதுல என்ன கொஸ்டின் வரும், மூணு கொஸ்டின் என்னன்னா வெயிட் ஆஃப் த பேபி வந்து it has to be more than 1000 grams, number one. Gestation period has to be more than 28 weeks. And third thing has to be crown heel length has to be more than 35 centimeters. Fine.
Okay, sir.
Okay. So இப்போ இது வந்து பெரிநேட்டல் மார்டாலிட்டி ரேட். பட் ஆக்சுவலா பெரிநேட்டல் பீரியட் அப்படின்னா வந்து it is more than 22 weeks. If someone asks you what is perinatal period அப்படின்னா it is more than 22 weeks. Okay, this is an
Okay,
additional
sir.
point which you can remember. Fine. Okay. Next, this is the most important thing in all the ratios. So maternal mortality ratio அப்படின்னு சொல்றோம். Why is it called a ratio? See, what is the difference between, நமக்கு மூணு விஷயம் இருக்கு. ஒன்று ரேட்டு, ஒன்று ரேஷியோ, இன்னொன்று ப்ரொபோர்ஷன். கரெக்டா? இப்போ ரேஷியோ பொறுத்த வரைக்கும் நியூமரேட்டர் இஸ் நாட் அ பார்ட் ஆஃப் த டினாமினேட்டர். நியூமரேட்டர் இஸ் நாட் அ பார்ட் ஆஃப் த டினாமினேட்டர். நாட் அ பார்ட் ஆஃப் டினாமினேட்டர். என்ன எக்ஸாம்பிள்? மெட்டர்னல் மார்டாலிட்டி ரேஷியோ. இங்க பாரு, மெட்டர்னல் மார்டாலிட்டி ரேஷியோ எப்படி கால்குலேட் பண்றோம்? பேஸ்ட் அப்பான் நம்பர் ஆஃப் மெட்டர்னல் டெத்ஸ் divided by total live births. So there is no relation between numerator and denominator. Maternal death is a separate entity and total live births is a separate entity. So that is the reason it is called as maternal mortality ratio. So ratio nale numerator is not linked or not um, coordinated with the denominator. This is what you have to remember. And the second thing is that idhula multiplication factor is low. Very important, it is 1 lakh. Maximum we have seen நார்மலா வந்து பர்சன்டேஜ் 100, மற்ற எல்லா ரேட்ஸுமே 1000ல மல்டிப்ளிகேஷன் ஃபேக்டர் இருக்கும். பட் மெட்டர்னல் மார்டாலிட்டி ரேஷியோ வில் ஹேவ் அ மல்டிப்ளிகேஷன் ஃபேக்டர் ஆஃப் அரௌண்ட் 1 lakh. This is very important which you have to remember. Fine. 3 things I have discussed. சரி, ஓகே. மெட்டர்னல் டெத் எப்படி டிஃபைன் பண்றது? மெட்டர்னல் டெத் இஸ் டிஃபைன்ட் as a death less than 20 to 42 days after delivery. Or termination of pregnancy. So 42 days kulla if you have death அப்படின்னா you call it maternal death, and it should not be either accidental or incidental causes. It has to be related to maternal cause, something related to pregnancy. A death which happens something related to pregnancy less than 42 days. So I'll expect you to remember this 42 days, number one. The second point is number of maternal deaths divided by the total live births. That is the reason it is called as a ratio. So ratio and understanding namakku numerator is not linked or not derived from the denominator, not a part of the denominator. Fine. Number 3 is what is the multiplication factor? It is 1 lakh. So 3 points we have learned right now. 42 days. It is a ratio. So number of maternal deaths divided by total live births. And number 3 is multiplication factor is 1 lakh. Fine. Yes. Aditha, I would want you to know about DALI. What is DALI? DALI is disability adjusted life years. Disability adjusted life years. So quality, it is quality associated life years. Quality adjusted life years. So இங்க வந்து disability you have quality. ஸோ நமக்கு என்ன கொஸ்டின் வரும் இதுல இருந்து அப்படின்னா, இப்போ இந்த டேலி அப்படிங்கிறது இட் இஸ் இந்த YLL அப்படின்னா என்ன அப்படின்னா வந்து இயர்ஸ் ஆஃப் லைஃப் லாஸ்ட், இயர்ஸ் ஆஃப் லைஃப் லாஸ்ட் பிளஸ் இயர்ஸ் லாஸ்ட் டு டிசபிலிட்டி. ஸோ என்ன அர்த்தம் அப்படின்னா வந்து, ஃபார் எக்ஸாம்பிள், இப்போ there is a birth, he is expected to live for 70 years வச்சுக்கலாமே. இப்போ இவனுக்கு ஒரு 50 இயர்ஸ்ல he is suffering from an accident, so he has lost his leg அப்படின்னா, so remaining 20 years he will remain with disability. இது ஒரு ரீசன். செகண்ட் ரீசன், ஒரு 40 இயர்ஸ்ல he has been diagnosed with cancer அப்படின்னா, he passed away at 45 அப்படின்னா, ரிமைனிங் இருக்கிற அரௌண்ட் 25 years he was dead early because of premature death. ஸோ நான் என்ன சொல்ல வரேன் அப்படின்னா, ரெண்டே விஷயம் தான் ஞாபகம் வச்சுக்கணும் இதில். டிசபிலிட்டி அட்ஜஸ்டட் லைஃப் இயர்ஸ் பொறுத்த வரைக்கும் நம்பர் ஒன் இஸ் இட் இஸ் இயர்ஸ் ஆஃப் லைஃப் லாஸ்ட், எவ்வளோ சீக்கிரமா இறந்துருக்காங்க அப்படிங்கிறத வச்சு நம்ம சொல்றோம், பிளஸ் இயர்ஸ் லாஸ் டியூ டு டிசபிலிட்டி, ஏதாவது ஒரு டிசபிலிட்டி வந்துருச்சு, இது ரெண்டையும் சேர்க்கறது தான் டேலி, DALY. இப்போ நமக்கு இன்னொரு கொஸ்டின் வரும், எந்த இண்டிகேட்டர் வந்து வில் சே த ஓவரால் பர்டன் ஆஃப் த டிசீஸ், ஓவரால் பர்டன் ஆஃப் த டிசீஸ் இஸ் டெபிக்டட் பை டேலி. ஸோ இப்போ இந்த கொஸ்டின் வந்தாலும் யூ வில் ஆன்சர் தட் த ஓவரால் பர்டன் ஆஃப் டிசீஸ் is indicated by DALI, which is disability adjusted life years. சரி, அப்போ குவாலினா என்ன? குவாலிட்டி அட்ஜஸ்டட் லைஃப் இயர்ஸ். ஸோ வாட் யூ ஹேவ் டு நோ, இதுல குவாலிட்டி ஆஃப் லைஃப் கேம். சரி, இதுல என்ன கொஸ்டின் வரும் அப்போ? இட் இஸ் த காஸ்ட் எஃபெக்டிவ்னஸ் ஆஃப் அன் இன்டர்வென்ஷன். நம்ம ஒரு இன்டர்வென்ஷன் கொடுக்குறோம், ஃபார் எக்ஸாம்பிள் வி ஆர் ட்ரீட்டிங் ஹிம். இன்டர்வென்ஷன் கேன் பி எதர் ட்ரீட்மெண்ட், இட் கேன் பி எதர் எனி டயக்னோஸ்டிக் ப்ரொசீஜர், இட் கேன் பி எனி chemo procedures, any procedure. That is what is an intervention mean. ஸோ எவ்வளோ எஃபெக்டிவா இருக்கு அந்த இன்டர்வென்ஷன் அப்படின்னு சொல்றது தான் வந்து குவாலிட்டி அட்ஜஸ்டட் லைஃப் இயர்ஸ். ஃபைன். ஸோ வி ஹவ் ரெட் டூ திங்ஸ், குவாலி அண்ட் டேலி. ஓகே, சொல்லு திலீஷ், are you there online?
Yes, sir.
சொல்லுமா. I want other people also to be active. வேற அருண் இருக்காங்களா?
Yes, here.
அச்சா அருண், are you understanding Tamil? Hello?
Unfortunately, I don't understand Tamil, so please.
Okay. So that is what I was asking in the initial thing, no? That if everyone can understand Tamil or I can take classes in Tamil. Okay, I'll proceed with English then. It's okay. Are you
Thank
getting
you.
till?
I appreciate it.
Are you getting till that? Till this whatever we have gone through, Arun? Are you having an idea regarding this? Regarding the mortality rates and regarding the quali and DALI? Fine. Jayaprakash and Gaurav, are you active?
Yes, I'm here.
Okay, Arun is here. Jayaprakash and Gaurav.
Yeah, up to now, everything is clear.
Okay, yes. So Dilesh, we have discussed about the maternal mortality ratio and quali and DALI. Okay, what will you remember in maternal mortality ratio?
The maternal death, 42
Okay,
days, either
42
by
days is number one. Number two,
second is the maternal death by TLB,
okay,
and MF is gonna be 1 lakh or 100,000.
yes, multiplication factor is it's going to be 100,000 or 1 lakh. And why it is called as a ratio? Because numerator does not become a part of a denominator, right?
Dominating, yes.
Yes, that is why it is called as a ratio. And coming on to DALI, what are the points which we have read in DALI? Disability adjusted life years. You have two things.
First is the years life lost, and
Yes,
years lost due to
due
disability.
to disability. Fine. So if there is another question where you will say that overall burden of a disease is exhibited by
By
DALI.
daily.
Yes. And what is quali? What will you remember in quali? You have only one point to remember. If someone asks you what is the cost effectiveness of an intervention, you will say it is quali, quality adjusted life years. Fine. Yes. Fine. The next thing which we'll go is you have HDA. What is HDA? HDA is Human Development Index. Human Development index. And what is PQLI? PQLI is physical quality of life index. So I'll expect you to remember only 3 points here. You have 3 components in HDI. You have 3 components in PQLI. So the 3 components are the life expectancy at birth, number 1. Number 2 is standard of living. And number 3 is knowledge. The standard of living is based upon gross national income. What is GNI? It is gross national income. And this knowledge is based upon expected years of schooling, expected years of schooling, plus mean years of schooling. Plus mean years of schooling. So no one is going to ask you this. They are going to ask you the components. The 3 components which you have to know in HDI is, one is life expectancy at birth, number 2 is standard of living, and number 3 is knowledge. When it comes to PQLI, which is physical quality of life index, you have to know about 3 things. Here it comes life expectancy at 1 year. Here it is at birth. Here it is at 1 year. Right? And number 2 is infant mortality rates. And number 3 is literacy rates. 3 things we have discussed here. One is life expectancy at 1 year. Number 2 is infant mortality rates. And number 3 is literacy rates. So when it comes to HDI, you have 3 components, which is life expectancy at birth, standard of living, which is calculated by gross national income, and knowledge is calculated by expected years of schooling plus mean years of schooling. When it comes to PQLI, which is physical quality of life index, you have 3 things, where you have life expectancy at 1 year, infant mortality rate, and literacy rate. 3 things you have to remember here as well. Then I'll go into AEFI. What is AEFI? It is adverse effects following immunization. Adverse effects following immunization. Fine. See, actually, there are 2 types of adverse effects. One is local adverse effect, where you will have pain, swelling, fever, all those local effects you have. One more, you have systemic side effects, which are very severe comparatively. So we are knowing about the systemic side effects basically. So coming on to BCG, I want you to remember lymphadenitis, which is usually suppurative. Suppurative lymphadenitis is one thing which I wanted you to remember in BCG. In hepatitis B, you have anaphylaxis. In MMR, you have thrombocytopenia. In DPT, you have HHE. What is this HHE? HHE is hypotensive, hyporesponsive episodes. HHE is hypotensive, hyporesponsive episodes. And you have inconsolable crying also. In rota, you have intussusception, which is nothing but coiling of intestines. Coiling of intestines. And influenza, you have Guillain-Barré syndrome. This is Guillain-Barré syndrome. Fine. So we have discussed about 6 vaccines. Number 1, BCG, you have lymphadenitis. Number 2, hepatitis B, you have anaphylaxis. Number 3, MMR, you have thrombocytopenia. Number 4, DPT, you have HHE, which is hypotensive, hyporesponsive episodes and inconsolable crying. Number 5, you have rotavirus, which causes intussusception. Number 6, you have influenza, which causes Guillain-Barré syndrome. Right? Okay, is Dilesh online?
Yes, sir.
Okay, Dilesh. So what we have discussed regarding the last 2 slides, HDI and PQLI and 3 components.
Yeah.
So what are the 3 components in
Human
HDI?
Development Index and
Okay, what are the 3
PQLI
components? Physical
life
quality of life
expectancy at
index.
birth.
Okay. Number
HDI
2 is
life expectancy. Second on the standard of living.
okay.
Third is knowledge about the
The
expected
knowledge
years
is calculated based upon the schooling. Okay.
full year.
So you will get an all except question. இப்போ உனக்கு என்ன கொடுப்பாங்க அப்படின்னா வந்து you will get a question based upon all other components of HDI except all other components of PQLI except. Okay. So in case of PQLI, you will say three components. Number one is
Life expectancy at 1 year and infant mortality rate, literacy rate.
Yes. Three components you have to remember. அவ்வளவுதான். Next slide. Then AEFI and what is AEFI? It is adverse effect following immunization.
Following immunization.
சரி, ஓகே. நம்ம என்ன ஞாபகம் வச்சுக்கணும்? ஒரு வேக்சினுக்கு மெயினான சைடு எஃபெக்ட் மட்டும் ஞாபகம் வச்சுக்கணும். ஓகே. So we are only concerned about the serious side effects. So what BCG causes? Lymphadenitis,
hepatitis B, anaphylaxis,
MMR,
thrombocytopenia, DPT, hypotensive hyporesponse episodes, inconsolable crying, rota on the interception, influenza on the Guillain-Barré.
Yes, good. Fine. All these are adverse effect following immunization. Okay, next. VVM. Do you have any idea regarding VVM? What is VVM? VVM is vaccine vial monitor. See, whenever we want to use a vaccine, we have to check that whether the vaccine can be reused or not. For example, every vaccine consists of an outer circle and inner square. See, this concept of vaccine vial monitor was introduced just to make sure that whether we can use the vaccines or not. See, we have partially reused vaccines. See, we use a vaccine at one time, then again we store it in a cold storage, then again we can use it. So how can we know that the vaccine can be used or not? It is based upon this vaccine vial monitor. You have to remember only one thing. See, you can use the vaccine once the color of the inner square, if the inner square color is lighter compared to the outer circle. If the color of the inner square, so you will get an image. You will get an image showing vaccines, and they will ask you that which type of vaccines can be used in the above or in the below. So you are looking for the vial. When you see that the color of the inner square is lighter compared to the outer circle. For example, this is white and this is dark, or this is light blue. This is dark black. So what I'm trying to say is that when the color of the inner square is lighter than the outer circle, you can proceed with using the vial. You can use the vial. In case if it is of the same color, both the inner square and outer circle is of the same color, or the inner square is darker. If it is darker or same color, you have to discard. You should not use the vaccine. Fine. That is what we are trying to say. You should discard the vaccine. So what are the points which you have to remember here is that you may get an image showing the vaccine vials, and they will ask you which can be used. Number one, you have to remember this. And the use of this is mainly, for your understanding, I'm saying this, to reduce the vaccine wastage. And number three is heat sensitivity of the vaccine can be identified. And one more point I wanted to add here, the most heat sensitive vaccine is OPV. And the least heat sensitive is hepatitis B. Two things you have to remember as well. Right? So the heat sensitivity of vaccines, the most heat sensitive vaccine is OPV. And the least is hepatitis B. And in this vaccine vial monitor, you might get an image showing an inner square and outer circle. If the inner square is lighter, you can use the vaccine. If it is of the same color or if it is darker, you should discard the vaccine. Fine. Yes. And one more thing which you want to know is that open vial policy. What does that mean, open vial policy? See, once the vaccine is opened, you're opening the vaccine, you have to use it within 28 days or 4 weeks. You can use the vaccines up to 4 weeks. You can open the vaccine, you can use the vaccine, and again you can close it and you can cold storage it, and afterwards you can use till 4 weeks. But it is not applicable for two majorly. It is not applicable for BCG and it is not applicable for measles. You have to use it within 4 to 6 hours. You have to use BCG, you have to use measles. Both these vaccines. So I want you to remember, number one, 4 weeks or 28 days. 28 days. It's not 30 days, it is 28 days. And number two is you have to remember about BCG and measles. And clearly, we also had rota. In this list, but right now, rota also can be used till 28 days. What I'm trying to say is that open vial policy is not applicable to BCG, measles, rota and JE was previously added in this list, but right now, they are not in the list of open vial policy. They are not exceptions for open vial policy. Fine. So I want you to remember 2 points. Number one is 28 days. Number two is it is not applicable for BCG and measles. Fine. Yes. Regarding this cold chain, the first thing you have to remember is the temperature. So when you call it a freezer, the temperature obviously has to be high. So it is minus 15, 25 degrees Celsius. Remaining all the other three is walk-in cooler, ice line refrigerator, front load refrigerators, plus 2 to plus 8 degrees Celsius. So one more point is, what are the vaccines stored in freezers? It must be OPV because it is the most heat sensitive vaccine. So in freezers, you have to store OPV. Fine. In case of walk-in cooler, ice line refrigerator, and front load refrigerator, I want you to remember ILRs. ILRs are usually used at the PHC level. Primary health center level, you use ILR. What is ILR? Ice lined refrigerator. And number two, what you have to remember, you have separate zones for vaccines. You have separate zones for each vaccine. Fine. So the two things which you have to remember about cold chain is, see, the cold chain is nothing but the method of storage and transportation of vaccines. This is for your understanding. Storage and transport of vaccines from the site of production to the peripheral centers. So here we have freezers, two freezers, walk-in and deep freezer, where the temperature is minus 15 to minus 25 degrees Celsius. In case of walk-in cooler, in case of ILRs, in case of front load refrigerators, you have plus 2 to plus 8 degrees Celsius. So another point which you have to remember about ILR is it is the one which is used in PHCs, and you have separate zones and vaccines, separate zones for vaccines. Right? Okay, what are the last three slides which we have discussed? Is Arun online? Hello? Dilesh, சொல்லுமா நீயே சொல்லு என்ன பார்த்த லாஸ்ட் த்ரீ
சார் லாஸ்ட் வந்து நம்ம பார்த்தோம் வந்து அட்வர்ஸ்
effects following immunization அது முடிஞ்சா ஓகே you say about vaccine vial monitor. What did you learn about vaccine vial monitor? என்ன புரிஞ்சது?
heat sensitivity of vaccine, then second வந்து inner square lighter than outer circle,
இல்ல உனக்கு என்ன புரியுதுன்னு நீ என்ன அண்டர்ஸ்டாண்ட் பண்ணிக்கிட்ட? அது ஓகே, அது இருக்கிறது ஓகே. உனக்கு என்ன புரியுது? ஆக்சுவலி ஒரு இமேஜ் கொடுத்துருவாங்க வேக்சினோடது, உனக்கு வாட் வில் யூ அண்டர்ஸ்டாண்ட்?
இமேஜ்ல வந்து ஃபர்ஸ்ட் we should see the inner part, inner square எப்படி இருக்குன்னு நம்ம வந்து ஃபர்ஸ்ட் பார்க்கணும். அது லைட்டா இருக்கா டார்க்கா இருக்கான்னு பார்க்கணும், அவுட்டர் விட இருக்கான்னு பார்க்கணும்.
எப்ப யூஸ்
எது
பண்ணலாம்?
இதுவா இருக்குன்னு இது வந்து ஹீட் சென்சிட்டிவிட்டி ஆஃப் வேக்சின்.
இல்ல அது ஓகேமா, நீ வேக்சின் வந்து எப்ப நீ யூஸ் பண்ணுவ? கலர் பாக்குற, கலர் பார்த்துட்டு இன்னர் ஸ்கொயர் பாக்குற, அவுட்டர் சர்க்கிள் பாக்குற.
ரொம்ப டார்க்கா இருந்துச்சுன்னா யூஸ் பண்ண மாட்டேன் சார். உள்ள டார்க்கா இருந்துச்சுன்னா யூஸ் பண்ண மாட்டேன். ஒயிட்டா இருந்தா மட்டும் தான் யூஸ் பண்ணுவேன். இல்ல
ஒயிட்னு கிடையாது, லைட்டா இருக்கணும். அது ப்ளூவா இருக்கலாம், லைட் ப்ளூவா இருக்கலாம். அவுட்டர் இருக்கிறதோட லைட்டரா இருக்கணும் கலர். ஃபைன். ஸோ த நம்பர் 1. இதே சேமா இருந்தா யூஸ் பண்ணலாமா? ஓவராலாவே லைட் ப்ளூ கலர் இருக்கு, யூஸ் பண்ணுவியா?
ஃபுல்லாவே லைட் ப்ளூவா சார்?
ஃபுல்லாவே இது ஃபுல்லாவே லைட் ப்ளூவா இருக்கு. ஃபுல்லாவே லைட் ப்ளூவா இருக்கு. யூஸ்
யூஸ்
பண்ணலாமா?
பண்ணுவேன் சார்.
பண்ணக்கூடாதுமா. அதான் சொல்றேன்ல, இங்க பாரு. டார்க் கலரா இருந்தாலும் சரி, சேம் கலரா இருந்தாலும் சரி, டிஸ்கார்ட் பண்ணிடணும். இன்னர் ஸ்கொயர் வெளியே இருக்கிற சர்க்கிளோட லைட்டரா இருந்தா மட்டும்தான் யூஸ் பண்ணணும். See, I'm not concerned
Okay,
about the
sir.
color. Light blue, white, we are not concerned about that. We are only concerned about one thing. The inner square has to be lighter compared to outer
Okay, sir.
circle. புரியுதா?
Only
So,
inner circle or the outer circle color?
yes, we are only concerned about the inner square color. And even if the color is same with the outer circle, we should not use that.
We should
Fine.
discard it.
Okay, sir.
Yes, we should discard it. The second thing is that open while policy. What are the 2 points which we have discussed in open while policy?
We can use up to 4 weeks, sir. Now,
4 weeks,
28 days.
28 days, fine.
So,
சரி.
இது ஓப்பன் வைல் நம்ம எதுல யூஸ் பண்ண மாட்டோம்னா பிசிஜியும் மீசல்ஸ்லயும் யூஸ் பண்ண மாட்டோம்.
Yes, that is
Because
what
they
you have
stand
to
up
do. BCG.
6 hours.
Yes, 4 to 6 hours குள்ள நீ யூஸ் பண்ணி டிஸ்கார்ட் பண்ணிடணும். Fine.
ஆமா சார்.
Okay.
And Rota
What
and JE exception for 4 to 6 hours.
No, actually,
ஆனா
see,
இப்போ
Rota and JE was also in this list of 4 to 6 hours. Right now, these two has been
Can be used
into,
for 28 days.
you can also use it for more than 4 to 6 hours. Fine. In the previous thing,
Okay,
if you
sir.
will see, all these 4 vaccines were under this list. But right now, only BCG and measles is there. Okay. கடைசியா இப்போ ஃப்ரீசர் கோல்ட் செயின் பத்தி என்ன பார்த்தோம்?
கோல்ட் செயின் வந்து ஸ்டோரேஜ் அண்ட் டிரான்ஸ்போர்ட் ஃபார் வேக்சின்ஸ்.
இல்ல ஓகே ஃபைன். இது வந்து ஐ ஜஸ்ட் செட் ஃபார் தி ரெஃபரன்ஸ். நான் क्वेश्चन என்ன? ரெண்டே क्वेश्चन தான் அதுல. 2 things you have to remember. என்ன ரிமெம்பர் பண்ணணும்? ஒன்னு டெம்பரேச்சர்.
இன்னொன்று
Temperature
வந்து
is
நம்ம
-15 to -25.
-15 to -25 degree.
-25. See, when it is freezer, when you see the word freezer,
Deep
it is
freezer.
-15 to -25. Remaining all it is +2 to +8. Number 1. And number 2 is, in case freezers, you use OPV because it is the most heat sensitive vaccine. Fine.
ஆமா சார்.
ஃப்ரீசர்னாலே ஓபிவி தான் ஸ்டோரேஜ், அதுக்கு தான் இம்பார்ட்டன்ஸ் கொடுக்குறேன். ஃபைன். அதே மாதிரி ரிமைனிங் ஆல் த அதர் த்ரீ we are focused on ILRs. ILRs are ice line refrigerators, which is used in PHC, where you have separate zones for separate vaccines. Clear? Yes.
Yes, sir.
See, the next thing what I wanted you to know is that you will get a vaccine and they will ask you which type of vaccine it is. Which type of vaccine it is. Whether you have to know it is live vaccine, or it is killed vaccine, or it is toxoid. And I don't think that you could be able to remember all these things. You can have a mnemonic for it. Whether I followed this mnemonic from a source. Most beautiful place in the world is Rome. So I'll just write the vaccines. This is measles, BCG, plague, IPV, typhoid, yellow fever, PV, mumps, J. And this killed one is RIP is RS to Bella. Again IPV. Date. See, what I'm trying to say is that you can have your own mnemonic and you have to know the types of vaccines. They might give you an image of a vaccine and they might ask you whether it is live vaccine, killed vaccine. When it is toxoid, it is DPT, diphtheria, pertussis, and tetanus. When it is polysaccharide, coccus, the two coccus which we know is pneumococcus and meningococcus. Pertussis. Recombinant, you have to remember hepatitis B and Lyme's disease. See, what I'm trying to say is that you have to know what are the vaccines which are live, And live vaccines are always contraindicated in pregnancy. What are the killed vaccines? Toxoids mein you have DPT, which is diphtheria, pertussis, and tetanus. Polysaccharides. Saccharides are always coccus. In coccus, you have pneumococcus and meningococcus. In recombinant vaccines, you have hepatitis B and Lyme's disease. Okay, coming on to clinical trials. In clinical trials, there are 4 phases. Phase 1, 2, 3, 4. What you have to remember here, number 1 is the population. See, if it is 10 to 100, it is phase 1, 50 to 500, phase 2, 500 to 3000, phase 3, and if it is large means it is according to the study which we do. It is according to the study. So the first point I want you to remember is that how many population is being trialed in phase 1. It is still 100. In case of phase 2, 500. Phase 3, 3000. And phase 4 is large. So the most important part is that what are we looking for in phase 1? We are looking for the safety and tolerability of a drug. We are looking for the safety and tolerability. These words are very important because they'll directly give you these words and they'll ask you safety and tolerability is looked in which phase of clinical trial. So you have to say that safety and tolerability is phase 1, whereas if it is efficacy and dose ranging, it is phase 2. If it is use, therapeutic use and adverse reactions, it is phase 3. While it is drug interactions and rare side effects, it is phase 4. So this is called as post-marketing surveillance. Phase 4 is always called as post-marketing surveillance. So I have discussed 4 phases of clinical trials, phase 1, 2, 3, 4. In phase 1, till 100 people, phase 2, 500, phase 3, 3000, phase 4 is large. So in phase 1, safety and tolerability of a drug is looked for. Phase 2, it is efficacy and dose ranging. Phase 3, it is therapeutic use and adverse reactions. Phase 4, it is drug reaction, interactions and rare side effects. It's known as post-marketing surveillance. These are the 4 types of clinical trials. The next thing which I wanted you to remember is that evidence-based medicine, you have evidence-based medicine. So you have a pyramid in research. What does that mean? See, we are saying that case series and report is better. See, whenever there is a pyramid, this is the highest level. This is the lowest. So what we are trying to say is that in the evidence-based medicine and research, in research, which study seems to be the superior most? So I want you to remember only one thing. If they'll give you which ranks in highest efficiency in case of research is meta-analysis. This is what you have to remember. Meta-analysis stays in the highest rank or highest position in case of research. Okay. And second is systematic review. Systematic review. Then you have RCT, which is randomized controlled trials. You have cohort, you have case control, and finally you have case series and report. So I want you to remember only one thing, that meta-analysis is the highest. Meta-analysis is the highest rank in case of research based pyramid. So this is one question which I would want you to remember. Right? Yes. Okay, we'll go into study designs now. Okay, Nilesh online.
Yes, sir.
சொல்லுமா vaccine சொல்லு type of vaccines. What did you learn? Live, killed,
Type of
toxoid,
vaccines.
polysaccharide, recombinant. See, live vaccines, you can know as such, you can follow any mnemonic. The one point which you have to remember it is contraindicated in pregnancy. Okay, yeah.
Okay, sir.
அதே மாதிரி killed vaccines, RIP, ACE. So you can know the vaccines. And finally, you have to know that all these are killed vaccines. Direct question வராது, like which of the following is a killed vaccine, அப்படி வராது. But you have to know this because you can apply it in some other place. Number 3, toxoid, polysaccharide, and recombinant, you can get questions. Toxoid, na, it is only DPT. D is for diphtheria, T is for pertussis, T is for tetanus. Polysaccharide அப்படின்னா all the coccus. என்ன coccus இருக்கு? We have pneumococcal vaccines, you have meningococcal vaccines. 2 coccus you have. All these are polysaccharide. In case of recombinant, it is hepatitis B and Lyme's disease. Fine. Lyme's disease vaccine will come under recombinant vaccine. Okay, yeah. Okay, clinical trial enna paathom.
Total 4 phases, sir. Phase 1 la வந்து 10 to 100 CFK and tolerability காக 50 to 500 வந்து efficacy and dose ranging, 500 to 3000 வந்து therapeutic use and adverse reactions.
Okay.
Phase 4 is about the post-marketing large drug interactions and rare side effects.
Yes. See, the population is one factor which you have to remember, which is 100, 500, 3000. Second thing is that phase 1, you are concerned about safety and tolerability. Phase 2, you are concerned about efficacy and dose ranging. Phase 3, you are concerned about therapeutic use and adverse reactions. If they will ask adverse reactions is looked for in which phase of clinical trial, you will say phase 3. Fine. In case of efficacy, you will say phase 2. In case of tolerability, you will say phase 1. In case of drug interactions, you will say phase 4. And the exact terms are very important. Okay, that is what I'm concerned about. And finally, evidence-based pyramid, which ranks the highest, which study?
Meta-analysis, systemic analysis.
First வந்து meta-analysis தான். ஒரே ஆப்ஷன்னா meta-analysis தான் நீ இருக்கணும். இது ஒருவேளை இல்லை அப்படின்னா, if meta-analysis is not available in your option, you can go for systematic review. Just a brief idea about meta-analysis is nothing but already we have many studies இல்லையா? We have cohort studies, we have case control studies. இந்த ஸ்டடியை எடுத்து இதுல ஒரு ஸ்டடி பண்றதுக்கு பேர் தான் meta-analysis. You are doing studies based upon the previous studies. You are not going and doing directly in the population. So that is meta-analysis. You are analyzing the studies which has already been taken place. Fine. So obviously this will be the highest in rank based upon research. Fine. Just two things are very important, which is cohort study. And the other one is case control study. In cohort study, I want you to remember that it is a forward-looking study. What does that mean? Forward-looking study, or it is a longitudinal study. Why do we call that? See, initially, the exposure is present. The exposure is present, and you are looking for the disease in the due course of time. For example, if a person is a smoker, you are looking for the incidence of lung cancer by following him up, follow-up for around 10 years. So what I'm trying to make you understand is that forward-looking study or longitudinal study or cohort study means that the exposure, for example, in this case, smoking is an exposure. So the exposure is present in the initial phase and we are following him up. Follow-up is present for 5 years down the lane or 10 years down the lane. And we are looking for the disease, whether he is getting positive for the disease. And this is known as cohort study. It is a forward-looking study. So the one thing which I would want you to remember is that the exposure is present in the initial phase. We are looking for the disease in the due course of time. Okay. So one thing what you have to know about the association is relative risk. What is this term relative risk? See, this relative risk says that it is the strength of association between cause and the effect. For example, smoking is the cause. What is the effect? Lung cancer is the effect. So the strength, how many people are smoking? For example, 10 are smoking. For example, 8 are being positive for lung cancer. So the association between smoking and lung cancer is strong. So to exhibit this, we have one indicator known as relative risk, which is nothing but it will indicate the strength of association between the cause and the effect in case of cohort studies. Fine. How will you calculate relative risk? They will give you a scenario and you have to calculate by incidence of disease in exposed divided by incidence of disease in non-exposed. For example, if smoking is present, how many people got lung cancer who have smoked? So that is exposed. Exposed, what is the meaning? they have been exposed to smoking, and how many people have got the disease without smoking. The average of this two will form the relative risk. So the crux of this, I would want you to remember that, see, relative risk is one thing where you will find the strength of association between the cause and the effect. First point. The second point is, what is the formula for that? The formula is incidence in exposed divided by incidence in non-exposed. Incidence in exposed divided by incidence in non-exposed. And what does incidence mean? Incidence is number of new cases. Number of new cases in a specific duration of time. The specific duration of time. What is prevalence then? It is both new cases and old cases. So incidence is only the new cases. Prevalence is both new and old cases. Okay. So we have read about relative risk. And one more term we have, which is attributable risk. What does this mean? It means that extent to which the disease can be attributed to the exposure. Attributed is also meaning the same. Like what they're trying to say is that how much the disease can be linked with the exposure. Fine. So what I want you to remember in attributable risk is that here you have the formula of incidence in exposed minus incidence in non-exposed divided by incidence in exposed into 100. Because it is a percentage, you multiply it by 100. The formula for relative risk is incidence in exposed divided by incidence in non-exposed, while the formula for attributable risk is incidence in exposed minus incidence in non-exposed divided by incidence in exposed into 100. So you will get a direct MCQ based on this formulas. You have to know the formulas so that you will just substitute the values and you will give the answer. Right? The next thing. So we have learned about cohort study, which is forward-looking study or follow-up study or longitudinal study, while case control studies are retrospective studies. What does retro mean? Retro means backward-looking study. So what are we trying to understand from here? Here the disease is present. So you're going back in time. And you're looking whether the exposure is present or exposure is absent. For example, a person has cirrhosis of liver. Cirrhosis of liver. So this is the disease he's having today, currently. In 24, he is having 2024. So you are taking history. You are asking him that how many years he has been consuming alcohol. So you're going back in time. He's saying 15 years. So what I'm trying to say is that the disease is present here. So you're looking for the exposure in the past. So the cases are the one with disease. And what does control mean? Or the one without disease, D minus. So you're going back time in both these and asking whether they have been exposed to alcohol or not. So this is the exposure. I hope everyone is clear. In case of cohort study, the previous study, we saw that exposure was present in the initial phase. In case control study, disease is present in the initial phase, and you're going back in time. You're asking history from the patient. You're recalling the patient and asking whether he has been exposed or not. Clear? So one more important point, what you have to remember in case of case control study is odds ratio. What does that mean, odds ratio? As we have seen relative risk, we have seen relative risk in case of cohort study. The same thing in case control, it is odds ratio. It is the strength of association between the risk factor and outcome in case control study. See, the risk factor, for example, we have taken alcohol. The outcome, we have taken cirrhosis. So how much these two are associated? The strength of association is odds ratio. And the odds ratio is also known as cross product ratio. cross product ratio because it is this way. Okay, so what is the ratio? Odds ratio is equal to AD by BC. Cross product ratio, fine. So you just see here the exposure E present, absent. The cancer disease D present, D absent. So finally, we are just coming to know that if the disease is present, if the exposure is present, you say it A. Disease present, exposure is absent, it is C. Disease absent, exposure present, it is B. And disease absent, exposure negative is D. So you have to just remember that this odds ratio is nothing but a cross product ratio where you have to multiply in the cross angle way. Fine? Yes. Dilesh online?
Yes, sir.
Dilesh.
Sir,
Okay.
first cohort study.
What do you understand by cohort study?
Cohort study on the incidence of disease in
Leave all these
exposed.
things. Leave all these things. I am just concerned that what did you understand? See, it is a forward-looking study. Then a forward-looking study. Now, for example, exposure is present, exposure is absent. So you are following up time. Follow up. From now, you follow up for 5 years, 10 years, or 2 years, 3 years. Doesn't matter. You are waiting. You don't know whether the disease will occur or not. Fine. So what I'm trying to say is that the exposure is present initially.
Okay, sir.
Okay. Okay, fine. Yes. Then we'll ask Arun. Arun, are you online? So what does relative risk mean? Okay, fine. See, in case of cohort study, the exposure is present, and to find the association, we have relative risk. You have the formula of incidence in exposed divided by incidence in non-exposed. In case of attributable risk, you have the formula of incidence in exposed minus incidence in non-exposed divided by incidence in exposed into 100. This is the formula which you have to know. Fine. In case of case control study, you have the disease, you have cases who are disease positive, you have controls who are disease negative. So you go back in time. It is a retrospective study. What does retrospective mean? You're going back in time and you are looking whether the exposure is present or exposure is absent. So here you have one ratio known as odds ratio, which will define the strength of association between the risk factor and outcome. So you can see this is the disease, this is the exposure, disease present, disease absent, exposure present, exposure absent. So this is nothing but a cross product ratio. So it is AD by BC. Fine. So what is bias? When you go on for studies, no, you have to know about the basic biases. Bias is nothing but error. The literal meaning of bias is error in any study which we do. So I wanted to know about few biases. So what should we remember? What does that memory bias mean? It is a recall bias. As I have said in case control studies, you have to investigate or you have to ask the patient who is deceased whether he had the exposure or not. So there is a chance of recall bias or memory bias. This is one thing you have to remember. Number two is Bergsonian bias. What does this term mean, Bergsonian? It is mainly based upon the hospital admission rates. So what do I mean that? See, if it is hospital-based study, see, there are two types of studies. One is hospital-based, another one is community-based studies. If it is hospital-based study, the patients who are approaching the hospital vary from time to time. They vary from time to time. So what I'm trying to say, in case of urban, the hospital admission is high.
because the people are educated, they are very aware. In case of rural, the hospital admission is less comparatively. Fine. So because of the differences in the admission of the hospital, how many people are getting admitted, there is a chance of a bias which is known as Bergsonian bias. And in case of Hawthorne effect, what does that mean? Hawthorne. It means that, see, in case of cohort study is a study which we follow up. For example, I'm taking a patient who is a smoker and I'm following up for 5 years, for example. So this patient will change his behavior or change his attitude. Why? Because I am keenly following up. Because of my follow-up, there is a tendency to the change or alter in the behavior of the subject. He may either quit. So our study becomes biased. What I'm trying to say is that Hawthorne effect, you have to know that it happens in cohort study. And the second thing is that it is nothing but the tendency of the subjects to alter their behavior or change their behavior during the due course of time. So one more thing you have to remember is confounding bias. What does that mean, confounding? See, confounding means, see, there are two factors, factor 1 and factor 2. For example, smoking, cancer. Now I take alcohol as number factor 3. So alcohol is a confounder. Why? What does confounder mean? Confounder means confounder is related to A also, B also independently. For example, alcohol and smoking are related. They go hand in hand. And alcohol and cancer is also related. And these two are also related. What I'm trying to say is that confounder is one factor, which is a third factor. Confounder is a third factor, which is directly or indirectly related to both first and second factors. For example, in this case. Fine. So because of that, there's a chance of bias, which is known as confounder bias or confounding bias. And finally, you have Neyman bias. Neyman bias is prevalence incidence bias. So what does that mean? See, for example, I'm just taking the incidence of smoking with acute MI. See, in this case, the patients with smoking will die early compared to patients who are not smoking. So when the patient dies, he is excluded from my study. So my incidence and prevalence will change because of that. So I just want you to remember only one thing, that prevalence incidence bias is Neyman bias. Confounding bias is a third factor which is related to both factor A and B. Hawthorne bias is tendency to alter the behavior of the subjects. Fine, you just say the biases which we have read right now. We have read about biases, no? What is a bias?
Sir, it's a error in studies, you know.
Exactly. Okay,
So,
fine.
We have a memory bias that is called recall bias.
Okay.
Parkinson bias is used for the hospital admission rates.
Okay.
And anthronin bias is for the tendency to alter in behavior of subjects.
Okay.
And confounding bias is for the factors related to exposure and disease.
Okay.
Neyman bias is for the prevalence incidence bias.
Bias. Okay. You have to know all these 5 things which are basic biases which you will find in any studies. Okay.
Yes, sir.
Now I want you to know about case fatality rate. What does that mean? Case fatality rate. See, fatality is the killing power of the disease. It is the killing power of the disease. And case. So what you will do? Number of deaths because of a particular disease. Any disease. Because of any particular disease divided by number of cases because of the same disease. Number of cases because of the same disease into 100,000. This is case fatality rate. So what is the question which you will get? The first question which you will get is that Case fatality rate is nothing but the severity or killing power of a disease, number one. And it is mostly applicable for acute diseases. And number three is